We're going to kick off with a bit of a debate. I know our rapid response colleagues are in the room this morning, and what we wanted to do was have a conversation about maybe who drives change better in the NHS. So we have just joining us on stage here, we've got Celia Ingham Clark, who's the Medical Director for Clinical Effectiveness at NHS England. Next up is John Welch, President of the International Society for Rapid Response Systems. We've also got Peter Homa, former Nottingham University Hospitals Trust Chief Executive and now Chair of the Leadership Academy. And just getting mic'd up is Julie Bailey, who founded the Cure the NHS group and helped to expose the Mid-Staffordshire scandal. And we've got about half an hour, so not a great amount of time, but I wanted to kick off first of all with a little bit of a Slido poll for the room, and then we're going to ask our colleagues to get involved. So if you can get into your live Q&A, and I just wanted to kick off with a question via the app, which is about asking you guys in the room, who makes the biggest difference to improving safety? Is it frontline staff, or is it policymakers? Now, if you can get into the app, you should be able to find this question and be able to vote on this, and I'd be very interested to see the results of what you guys want to think about this. So please do vote on that question while we're having a conversation. But first of all, if I could just ask, Peter, you're a chief executive, you're on the panel here today. Talk to us about your perspective. You were there at the top of an organisation. Were you the one making the biggest difference to safety on the front line?
No. The role of leadership, and I was one of a number of colleagues, is to create the right climate within which great care, safe care can flourish. And I think, exactly as Kevin's magisterial presentation taught us, this has to be a shared purpose, literally from Whitehall through to individual primary care practices, hospitals, ambulance services. There has to be a shared purpose in delivering safe care, which includes very close attention to signals that may suggest that things, and to use Kevin's phrase, may be overheating.
John, you're a nurse consultant at UCLH, I believe. What's your view of this? It's surely the nurses, isn't it, that make the biggest difference?
Well, I'm here really as a representative of the rapid response movement, critical care outreach, as we call it in England, and that actually absolutely came from a recognition by nurses and doctors on the shop floor that there were significant numbers of patients who were deteriorating and that wasn't being recognized or acted on. And absolutely we've developed a system from the bottom up to try and address that. Not completely successfully, but with lots of success. And its success is shown by the fact that it's sort of spread across the UK and around the world, and very much driven from the bottom up, generally without any funding.
Okay. I'm being told there's a problem with our question on Slido, so I'm going to do it the old-fashioned way, okay? So put your hands up in the room now if you think it's the policymakers that make the biggest difference to safety in the NHS on the front line. Don't wait for it. Don't wait for it. Go. Okay, I think, well, there we go. We don't get much support there. So I think I know which way this vote's going to go. So is it the frontline staff that make the biggest difference to safety? Okay, by a large majority there. So Celia, if I can bring you in. So you are, if you like, a foot in both camps, aren't you, really? I mean, you are obviously a clinician, but you're a senior clinician working for NHS England, boo, hiss, maybe. So talk to us. Do you feel that, are you with the audience there, or?
I think the frontline staff are the key people to making a difference on patient safety, both in terms of having ideas because they see the problems, but also in terms of enacting the right thing once it's shown what the right thing is. I think our role at the centre is, first of all, to make sure we keep lots of contact with people on the front line so we pick up the good new ideas. But before we can say, yes, do this everywhere, we have to be confident that that idea will work in the real world, not just in the hands of one enthusiast. So it's important that we support people to evaluate systems, evaluate new things, not just tech, but new ways of doing things, like the ED safety checklist, like the introduction of PINSA, which is a medication audit tool in primary care, which has been really well evaluated, and I see it's won a poster prize here in the Congress. But we then, once we're sure that it's really going to work, our role is then to use our levers across the system to put it out into practice. So whether that's asking the CQC to inspect against it, or putting a CQIN, a financial lever, to encourage trusts to introduce something, such as the things for reducing the impact of sepsis that we've done recently. So that's what our central role is. But coming back to the front line again, you've also got to make sure that people are prepared to be followers as well as leaders. You do need some professional autonomy, particularly in some crises, but you've got to be sure that that consultant surgeon will do the surgical safety checklist properly and not just say, oh, that's something for the nurses to do. Yeah?
Yeah, break the silo perhaps there. Yeah. Julie, can I just bring you in here? Because we talk about policymakers, and obviously it's lovely to see you again, and I know you and I have known each other for going back about a decade now. And in relation to mid-staffs, we saw the policymakers contributing and actually causing systemic problems there. From the family and patient perspective, do you see the system as the problem here? The policymakers are a problem, and they get in the way of the frontline staff, or actually is your view that frontline staff are perhaps not doing what they need to do?
I think the problem is that the policymakers aren't listening to the frontline staff. It isn't done as a collaboration. And if it was, if the frontline staff could feed up to the policymakers and all work together and then keep feeding back that what the policy is working, and it is being implemented on the ward, and it is making a difference to patient safety. But that doesn't seem to happen. We seem to have policies from the top that come down, and the workforce, the frontline staff, they don't see the benefit. When they do see the benefit, and you've got the right leadership that galvanises the workforce behind it, and they can see that it is making a difference to patients, then those are the more successful changes.
And Kevin, you were nodding your head there. You agree that is that issue around the staff being heard?
Well, I mean, I think mid-staffs, when you look at it, is again exactly that example, is it not? I mean, you know, when you read the report and you look at Appendix I, which shows the serious untoward incidents forms that are completed, saying there are not enough nursing staff around on the wards, there are over 1,500 of those forms completed in the period 2005 to 2009. So where was that signal? And it's exactly, in architecture, it's exactly the same as the Challenger disaster, that people who you pay to be your experts to monitor and send signals aloft, then nothing is done. And so the problem, I think, is that, you know, this is more than culture. This is, all of these things are necessary, but alone are not sufficient. And so, you know, yes, we absolutely must improve the way that we approach safety and our safety culture within the NHS. Yes, we absolutely must improve the resourcing of that, because the two go hand in hand. And I think it's naive to think that that's not the case. Safety, it doesn't cost to care, is an interesting and easy aphorism. But in fact, it does.
Peter, the words leadership have been mentioned a couple of times. Obviously, in your new role, what is this an issue that leaders in the NHS don't quite know how to communicate with staff? Or some of them. I won't be too pejorative, but some leaders don't know how to actually hear those messages that Julie and Kevin are saying aren't getting through. And are we trying to address that problem? And maybe it works the other way as well, that staff don't necessarily feel able and willing and confident to speak the other way. So from a leadership academy point of view, are you alive to that issue?
We're very alive to the central importance of multidisciplinary, multi-level, effective and humble leadership, where the objective is most usually not to issue directives, but to give close attention to those, as Kevin describes, who have the exquisite responsibility of delivering care, often in very challenging circumstances. And I have to say, in my now 6 months involvement in the NHS Leadership Academy, I've had the privilege of meeting a range of leaders across the English and indeed the UK health services. And I'm really optimistic in that the leaders I see, including those at a very early stage of their career, have a much clearer focus than I had at that stage in my career. They understand the grammar and syntax of improvement, and they understand the importance of listening to staff. And if I may, I think a quality we haven't touched on explicitly, other than in Kevin's talk yet, is we need high trust environments. And we can't create those like instant coffee. It takes time, it takes often adversity where values and behaviors are tested. And in high trust environments, it is possible for staff to raise concerns in a way that feels absolutely safe. And I'm struck by Peter Drucker's work. I'm of a generation where he was one of my teachers. What gets measured gets managed. And it's absolutely important and central that we enrich the indicators which are given serious attention, as many organizations are, to include seminal markers and indicators of quality and safety. And there are some very good examples, including in Sherwood Forest, which has demonstrated a very considerable improvement over a relatively short period of time by the relentless focus on the improvement of these markers.
Okay, I don't want to do all the work today, so I hope you guys are going to submit some questions. I know you have done already through our Slido poll, but please do keep them coming. So hopefully the guys back there can put Slido up on the screen now, but I wanted to ask the panel a couple of thoughts about what they think about some of these questions. And there is a question here about the policy creators need to engage with frontline staff more. Quite often, policies aren't really fit for purpose. Celia, I'm looking at you, seeing as you work for NHS England. Do you recognise that criticism, and what would you say in response to that?
It is really important to listen to people from the front line, both getting out there to do visits, to actually listen to people in the multi-professional teams in the environments, but also listening to professional associations and colleges and so on, because they've got a very clear view of what needs to be done. We've got a bunch of national clinical directors who work for NHS England that in many cases we can use as our interface with individual professional groups. I have a particular interface with people regarding acute deterioration and sepsis because that's one of the things that's really important to me. But I know that the managerial staff in NHS England also recognise that importance of listening to the front line. Our job is to improve what happens in the NHS. It's not to invent things out in a separate bubble. It's actually improving services in the NHS. That's what they're there to do.
I wonder how much patients are involved in this process, Julie.
Well, very little. You know, what we heard from the public inquiry, the policies that had been set then, patients weren't involved at all. But if we did involve patients in the starter policies, same with frontline staff, we'd start at the very basics. You know, we put a new policy in onto wards that are short of staff. We don't look at the very basics of patient safety before we add different things in. You know, we can't, you wouldn't take a plane off without the right number of staff, without the right skill mix, but we expect our frontline staff to adapt with already, you know, they're already at a disadvantage, and then a new policy on top.
John, you wanted to come in.
So we've just come from a previous session where we asked to a room full of experts on deterioration how many of them worked in hospitals where the patients themselves are enabled to raise an alert if there's a problem in their care. And very, very few hands went up. So there's a sea change that's absolutely required to give patients the means to call for help in all kinds of ways if they need it.
Yeah. There you go. Everybody agreed. I wanted to raise one issue of a policy that is, I think, being suggested as a way of actually, that is making a difference, which is the rollout of the new News 2 tool, the National Early Warning Score. That is being effectively mandated through a change to a sequence. That's the policymakers saying, do this. but there's been a lot of clinical involvement, and the Royal College of Physicians has developed that. I mean, is that the kind of way we bring these two groups together and work? Is that a good... I know, John, you're aware of that. Celia, I think you've been involved as well, haven't you? And is that a good example of how we can bring the two tribes, for want of a better phrase, together?
I hope so. I mean, I wanted to do something about acute deterioration. I knew that NICE had promoted the use of early warning scores, and then I discovered that NEWS was the best validated one, and then there was an update on that. And for the last year, I've actually, on top of my day job, I've been the Interim National Director of Patient Safety. I was actually able to use this joint role to do something to introduce NEWS through both routes. So we've asked the patient safety collaboratives to get involved in making sure that NEWS 2 is the early warning system that's used universally across the NHS in acute care. And some of them, particularly West of England, AHSN, have started to move it out with great success into primary care as well. And then at the same time, through my NHS England side, I was able to make the change in the sequin that you say, so that people will get paid for the sequin from Q4 this year if they use NEWS 2 rather than another early warning score. And then we're building on that by starting to develop an equivalent, we hope, for paediatrics, although that's going to take us a little while to get there.
It's a good example of how to do it, isn't it, John?
It is a good example. And what I would say about NEWS, I was part of the writing of NEWS 1 and NEWS 2, is that what was really important is that frontline, absolutely frontline people were brought in to help with those projects. And there's an important difference between having eminent academics and professors of medicine who are writing stuff that is rolled out to nurses and healthcare assistants and junior doctors on wards, but probably don't really understand what that domain of work looks like.
Yeah.
And we saw an example with the original writing of the NICE guidance on sepsis, which was really a dog's dinner. And when rolled out initially, a national survey showed that most people thought it was unworkable. And great credit to Celia and some of her colleagues that they then listened to that signal, and it's been made much more practical and much more useful. But it's a sort of pity that wasn't there at the beginning. The NEWS is different. It has always had frontline staff contributing to its development.
There's the top voted question on our Q&A this morning. When shop floor staff are escalating their concerns of current pressures, what do you do when there is no more staff available and no finance to employ? And I think that kind of, it's a sort of very clear question about a practical problem, but actually we talk about staff. Kevin, you said staff say we haven't got enough people, you can't take the plane off without that, but what do the system leaders do? But I don't know whether any of you had a thought about that, because the workforce issue is a major problem, isn't it?
Yeah, I mean, it is. I used to be medical director of an acute trust, and I've certainly been in that situation. And the very first thing you do is you roll up your sleeves and you get in there and you listen to people on the ground to see what the exact situation is. It's no good just being there at a distance. You've got to be there to support your staff. And then you see what you can do to get other people to help, because there are quite a lot of people who've got a broad skill set. And if you ask them and they recognise it's an emergency situation, they will help. But this is crisis management, and I completely agree that in the long run, the way to address it is actually to improve the resources available across the system. But all of that takes time. We can't just produce additional consultant anythings or additional nurse specialist anythings out of nowhere. We have to train people in the right skills.
So there's a huge skill to managing acute surge, as Celia describes there, and it's difficult, but we keep it running from day to day, even when we don't have enough. I think that what we're very bad at is pre-agreeing and understanding what our hard deck level of staffing is for us to run safe practice. Now, the importance of that is not that you stop if you don't run at that level, because you often can't. And I would argue that almost every day in my current practice, we're running at below that level. But it is then for you to acknowledge that you're running at risk. And if you understand that organizationally you're running at risk, that changes the landscape of how we understand why and how safety incidents are happening. You know, as Judy rightly says, we look at the airline industry, but no one sits at the gate going, where's the co-pilot today? Oh, he's off sick. She's off sick. Well, let's just push back anyway because we've got to get the plane in the air. They don't do that. That is part of their safety success. They cancel that flight. We can't do that. But we should recognize what our minimum, as organizations, we should have a very clear view of what our minimum safe staffing levels are. I know there's a lot of debate about that, But you should at least idealize that and then iterate that so that you understand yourselves, because you can't say that any level of staffing is adequate, because it plainly isn't. And on the days when the worst things happen for us, they almost always correlate with the days when we were under push from something else. I've come and gone in the NHS as I've gone abroad and come back. I've seen the NHS in almost time-lapse photography over the last 20 years. And I come back sometimes and it looks awful. And I remember last October standing on the wards with us, unable to send for any, shorts and t-shirt weather, unable to send for any patients because we did not have enough beds. And I said, this is like winter crisis, guys, and it's, sunny weather. And they said, it's always winter now. Now, when you're at that stage, the latent risks in your organization are enormous, and yet you're sitting there all normalized to this. So my answer in the end is that we need to at least try and understand what minimum safe standards look like and be cognizant of when we're in breach of them.
We could have a whole session talking. A lot of support there for safe staffing levels, and maybe I can ask the Secretary of State about that and why he suspended the nice work tomorrow. But Peter, can I ask you about your work at Nottingham? Because I know we're talking here about policymakers versus front lines, and we've set that up purposefully to have the debate, but actually bringing in that question around staffing levels, I know that Nottingham, as I've seen it myself, during your term there, you developed some quite innovative tools and collaborated with your clinicians to create some great solutions to that problem, didn't you? So talk to us a little bit about how you did that and how everyone should do it.
Well, thank you for those comments. And it's really important I emphasize the ideas came from frontline staff.
Yeah.
And the role of leadership, when I had the privilege of counting myself in that number, was to create a listening environment, sure, every now and then a bit of money, including the use of smartphones. And it was led by an inspirational doctor, Dr. Mark Simmons, with a range of nursing and other colleagues, who basically, over a period of time, demonstrated the huge improvements in patient safety and the reduction in mortality that the application of the early warning score, supported through smartphones, achieved. And there are a range of other initiatives. And what my experience has taught me, by which I mean my mistakes, is the question is not if the opportunities for improvement exist, but if we choose to take them. And the key thing is giving very, very close attention to what patients say, what the loved ones say, and what staff say, and then in a structured methodology, harvest those ideas and prosecute them with energy and purpose. And if we do that across the system, and ideally across the country, then remarkable things will happen.
There's a question on Slido here from Claire Cox, which I think pulls across some of these issues, which is policies are often amended by the Trust out of knee-jerk reactions. The reason they're laughing, by the way, Kevin, is they think you should be the Health Secretary. You don't want that job, do you? Given the way the government is going at the moment, he could well be later this week. It's now getting 40-odd votes now, so I think... So Claire Cox, you're all not using this very seriously. So Claire Cox asks us a question, and I think it's actually really useful. Policies are often amended by the Trust out of knee-jerk reactions from when things go wrong. This causes confusion on the front line. What else can be done? I mean, that is a key issue, isn't it? John, you're a frontline consultant nurse. Do you recognise that point?
So there's lots of things that are missing, obviously, but I think one thing that we ought to recognise collectively is that we've got quite good at recognising deteriorating patients or people at risk. We're quite good at recognising acute illness, but there's very little systematic overview across the hospital of the dependency of patients, which can be very variable. And you go to 2 different wards, and there'll be one ward, there are 6 or 7 patients that are needing to be fed or turned or washed, and all of those activities take a lot of time. And the ward next door may be quite different in terms of that sort of workload, but they'll generally have the same number of staff to them, and we need to be smarter about recognizing in real time how dependent patients are and how that changes during the 24 hours, and tying it into acuity as well. But the dependency acuity, somebody's being rolled while somebody else is quietly dropping their blood pressure in the next bed. And often the dependent patients make more noise than the ones who are becoming seriously ill. and that's something that's really missing, I think, understanding the workload in the hospital.
Julie, I wanted to ask your perspective. That question that Claire asked about policies being changed as a knee-jerk reaction when things go wrong, often that might be because a family is obviously being harmed or is complaining or talking to the press or whatever. But the families don't want knee-jerk reactions, do they? That's not actually serving their interest.
No, that's right. We had a similar thing at mid-staffs where they introduced the comfort rounds. The comfort rounds were introduced, and staff went round and asked patients every 4 hours if they needed the toilet. But then they left that to another member of staff. So the patient wanted to go to the toilet, but then had to wait. It just didn't work. What patients want and relatives want is for the NHS to decide what works. And I know that's going to change along the way, but we need to sit down and work out what works. Like Peter said, it is trust. What works, what's good practice, and spread it throughout the NHS. We need more standardised procedures. The public patients, I've been on this agenda now for 10 years, and sometimes it feels like we're not getting any further. Like you said about, we need to be more savvy with the nurses so we can move them to different wards. Now, that's not rocket science. That we should have been doing that a long, long time ago from the public's perspective. It seems as if we're wasting resources when staff are struggling. Healthcare professionals are struggling on the front line. We need to be more intelligent.
Yeah, Kevin.
Just to tie this really to the rapid response work that Celia and John and the likes of have been working on. So that's a very good example of service I hate the phrase service improvement because it sounds like improving the production line at McDonald's or something. But it is a great example of how we've delivered care better over a period of time. And in that is the answer to the problem, which is evolution. It is not about revolution. So every system that I've looked at outside of medicine does not design its way into what it is. It evolves its way into it. And you look at NASA's Human Spaceflight Program, and you look at its non-human program. I went to Afghanistan to look at our military trauma provision there, which became the stuff of mythology because they were saving lives that had never been saved before. But when you ask yourself, what is it that makes this team like this team? It was a process of slow iteration and evolution, not going back over a few months or even a few years, but actually, when you talk to the military, that went back to Kosovo, and so 20 years of unfettered evolution and iteration. And that's what we need. We need the ability to be able to hear the signals wherever they emerge from, whether that be from the patients or from the clinicians or from not just clinicians, any healthcare worker. And we need to be able to feed that into our ability to iterate our systems. And we need to be able to evolve unfettered. You'll never depoliticize the NHS, but you need to reduce the political interference because it does not help us generally.
Well, we're coming to the last few minutes of the session, so I suppose we should start moving this towards the solutions focus that we want. And Peter, as the chief executive on the panel, I'm going to ask you, what is the secret sauce to switch the way this audience voted at the beginning? What can people do when they get back to their organisation to try and build the bridge between our two camps, if they are camps? What's you did it at Nottingham, and you've seen it elsewhere.
I think it's recognising that there aren't separate camps. We all have the same purpose. And making sure that institutional, system and national level, the top priority is patient safety. It's a resource-constrained environment. We have to make the very best use of the resources we've got.
Yeah. John, from your perspective?
So it's good to hear that. It doesn't always feel that we all share the same purpose in some of these organisations. I would say that we've got different perspectives. And if I was going to add anything, it would be, can we have a more grown-up debate with the public, our patients, the public, about what it is that they want from both the acute and primary care health service. And we're still in the position that we get a lot of patients who come to us who end up having aggressive treatment, sometimes intensive care, and probably if we'd had time to think about and talk about that ahead of time, they might choose not to have it because it won't be of great benefit to them, but they're entering into that environment in an uninformed way. And there's a lot of work to be done around making sure that people are well informed about their healthcare choices, and often they're not. And I don't think we do that.
Celia, can I ask you from your perspective, what can people do in their own organisations where they feel maybe that they aren't getting, either as a senior leader or as a frontline member of staff? What do you think people can do to kind of solve that problem?
I think really effective communication is important. I think people need to talk to others in their organisation, both their peers and people in the hierarchy, because unfortunately there is still a hierarchy in most healthcare organisations, but also talk to other organisations beyond. So, you know, locally there will be Health Watch, there will be the Health and Wellbeing Board, you've got national organisations and local organisations in the third sector representing patients, representing families, and they have a very important role to play too. So it's listening to the people who actually see the healthcare system on the ground and using what you learn from that listening to improve the safety for patients, for me.
And very quickly, Kevin, same question to you.
It's all about honesty and openness, isn't it? As it always is. It's about being honest and open about the signals you're receiving from wherever they come, and being honest and open about what they really mean and what that means we really need. And honest about the fact that sometimes that means that actually, in addition to all of the great cultural changes we're making, we also need additional resource. And we should have that honest discussion with the public. And if the answer is we do not have that resource, we need to be honest about that too. So.
Okay. And Julie, last words from you, if I can, around the patient involvement here.
The very basic for me is we need the right leadership within the NHS that creates the conditions so patients feel safe to speak up, relatives feel safe to speak up, and healthcare professionals feel safe to speak up. And then we need to get the very basics of patient safety right. That's the right skill mix, the right leadership, and the right staff numbers.
Okay, well, we're out of time, I'm afraid. I think this has been really thought-provoking. We've also found the next health secretary, so that's great. Hopefully, by the end of the 2 days, we'll have got the Prime Minister sorted as well. So I think if you can all join me in thanking the panel. Thank you, guys. That was excellent.